So the first topic is about preconception and prenatal genetic diagnostic options. So as all of you know, HHT is an autosomal dominant condition. So this means that 50% of your children will inherit this gene, and we're able to identify the gene in about 97% of families. And like Dr. Fondo was just talking about, one of the SMAD4 mutation, et cetera, but more typically the endoglin or activin receptor like kinase 1 mutations. So these are the mutations that we can actually look for. Pregnant people with HHT are not at higher risk of miscarriage than the general population. So it's really important once you're considering pregnancy that you have a pre-pregnancy consultation with an obstetrician. So this would be important also for if either partner has HHT. So even if this relates to the male partner, especially in this era of prenatal genetic diagnosis. Sorry, something just popped up on my screen here. Okay, so basically what an obstetrician will do is they're going to review your current health and HHT status and how this may be related to risk of pregnancy. We want to talk about optimizing your health prior to pregnancy. And this is really going to be an overarching thing. So related to HHT as well as any other medical complications that you may have. And this really gives you an opportunity to become informed about options related to inheritance. So there's 3 options for diagnosis. That would be pre-implantation genetic diagnosis, post-conception or during your pregnancy, and then post-delivery by testing the baby. So pre-implantation genetic diagnosis would be carried out on an IVF conceived embryo. So it's really amazing what we can do nowadays. And many women are delaying pregnancy for all sorts of reasons, and may or may not need to access IVF technologies. But what's exciting about IVF is that once an embryo is created, we can actually do a biopsy and look for specific genes. So we can actually look at all the chromosomes and we can test that and see whether or not the number of chromosomes is normal. But we can actually specifically test for genes, and if that gene from an affected parent is known. And that's why it's important, if either partner has HHT, that you seek this kind of counseling prior to or during the pregnancy, because this is something that we can actually test for. And then in this particular situation, if this is a pre-implantation genetic diagnosis, there would be an option to transfer unaffected embryos, so embryos which do not carry the HHT mutation. After conception, there are also options of what we can do. So basically, there's 2 options. The first would be done early at around 12 weeks, and it's something called chorionic villus sampling. And this is essentially a biopsy of the placenta. So there is a risk of miscarriage of about 1% with this procedure. So a lot of people choose to wait until after about 16 weeks when they can undergo an amniocentesis. And an amniocentesis is, as you can see in the picture up here, is we basically take a needle, we put it in through the mother's belly and then through the uterus and take some fluid from around the baby. And then we can use that fluid and we can test for the genetics of the baby. And I think, what I always talk to my patients about is there's risks to this procedure, and given the risk of the procedure, what would you do with the results of the information? So some people may some people will say, well, I would not do anything with these results. I'm happy to wait till after the baby's born and test, in which case I would say there's no point in taking the risk of this procedure. But through your pregnancy, you may also encounter other screen positive results. There may be a fetal abnormality on ultrasound or something, and you may be offered this procedure for other reasons than HHT. And in that time, it's actually, potentially worthwhile to think about, do I want to also, since I'm having an amnio anyways for another related reason, do I want to look for this HHT gene? And then the last thing would be after delivery. So we will offer every parent the opportunity for genetic testing on the cord blood. And as you can see here, this is actually from the umbilical cord. So this is not actually a blood test for the baby. The baby's not poked. We're able to get the information just from the cord blood. And there's several genetic societies that are stating that this is an important thing to consider in people who can develop complications in early ages as a pediatric patient, et cetera, and it's worthwhile knowing. And because this is an autosomal dominant condition, if people decline testing, which that's obviously your right to do, we would consider your child affected until proven otherwise, just because if they develop any symptoms or anything like that, and having a family history of HHT would be important to know once the child is being evaluated by a doctor at a hospital. So from the guideline, our expert panel recommended that clinicians discuss preconception and prenatal diagnostic options, including pre-implantation genetic diagnosis with HHT-affected individuals. As you'll notice, sort of going through, the quality of the evidence is not that high, but in a lot of this is really consensus, but we came to a very strong agreement about all of these things, and the strength of the recommendation was good. So the next point was about pregnant people with symptoms of brain vascular malformations should be tested in pregnancy with an unenhanced MRI. So pregnant people who have no symptoms of brain AVMs are a different population than those who have symptoms. So in the general populations of people who have HHT, screening for brain AVMs is not routinely performed in all countries. So you may or may not have had this test, and that would be fine. If you have that information, it's good to have. But asymptomatic patients who have not been screened don't require routine screening during pregnancy. And this is really because there's very limited data and lack of evidence about the specific risk of a brain bleed in pregnant women with HHT, and there's no conclusive evidence of an increased risk of a first bleed from a brain vascular malformation during pregnancy. So about 10% of women with HHT will present with asymptomatic brain AVMs. And if you have a known asymptomatic brain AVM, some studies favor conservative management. So basically meaning that we're just going to wait and observe and not treat. In people who have no symptoms, in most cases, the treatment will be deferred until after the pregnancy because of the low risk of bleeding through the pregnancy. In those people who are pregnant with HHT and have symptoms of brain AVMs, and especially those who've had a previous brain bleed, the recommendation is to do an MRI. We advise not to use gadolinium, so it's an unenhanced MRI, and this should be done in the second trimester. MRI is safe in pregnancy, and in fact, we use MRI to scan fetuses at some point, so fetal MRIs. So this isn't a test that anybody should be nervous about undergoing during the pregnancy. We know that the annual risk from a first brain bleed of a brain vascular malformation in HHT is somewhere between 0.4 to 1%, and it's lower than that of the 2 to 4% risk in the general population for sporadic brain AVMs. 0.5% of unscreened women will present with a brain bleed during pregnancy or in the postpartum period. So this is really a very low number. But in cases of prior bleeding, the risk of rebleeding is increased, and that risk is up to 30%. And it's mainly in the second and third trimesters and in the postpartum period, which is defined as 6 weeks after delivery. So the expert panel recommends testing with unenhanced MRI in pregnant women with symptoms suggestive of brain AVMs, and we had, again, a strong agreement on this point. So pregnant people with non-high-risk brain AVMs can labor and proceed with vaginal delivery. So this is always something, this is when I see patients who have HHT, this is something that we always have to discuss, is whether or not they can have a vaginal delivery. And I think, there's been a lot of times when doctors were uncomfortable, with knowing that a person has HHT and that they may have these vascular malformations, and so they recommended cesarean section. And cesarean section may be required for other obstetrical indications or perhaps related to some HHT complication, but not necessarily. So in this case, we can say that there's really been no reports of a pregnant person with HHT having a brain VM bleed during labor. And in symptomatic patients, and even in asymptomatic patients with a known diagnosis of brain AVM, it is good to review, obviously, with a multidisciplinary neurovascular team. And on a case-by-case basis, what may be recommended, again, you may just be recommended to have a normal vaginal birth with normal ability to be able to, push effectively, etc. And sometimes, though, what we would recommend is that if we don't want to increase the pressure in the brain, we can recommend that you have an epidural, and that the baby comes down, really down the birth canal. And then as an obstetrician, I can help with the delivery using forceps or a vacuum with some of the maternal efforts and have the baby vaginally. And that would be recommended if there were some higher risk circumstances that were identified. So really, again, case by case basis. And, you know, that being said, there are going to be cases in which the multidisciplinary team's opinion, including that of the neurosurgeon, may be to deliver the baby by cesarean section, and that's okay too. So the expert panel recommends that women with known non-high risk brain AVMs can labor and proceed with vaginal delivery. Patients may require an assisted second stage on a case-by-case basis. Okay, so next one is talking about pregnant people who have not been recently screened and or treated for pulmonary vascular malformations should be screened and treated in pregnancy. So what are the changes associated with pregnancy? So when a person becomes pregnant, there's a lot of physiological changes, and this happens in a very short period of time. And most of the changes are really affecting the vasculature, so the heart and all the blood vessels, things like blood pressure, heart rate, etc. So that will obviously affect the whole vascular bed, and this is where people with HHT potentially have issues. So we know that there's an increase in the cardiac output by about 30 to 50%, with a maximum effect at about 20 weeks, so about halfway through the pregnancy. And there's an increase in blood volume by 40%, with the maximum effect at about 28 weeks. And there's a lot of hormonal changes in pregnancy, so huge changes in estrogen levels, progesterone levels, and there's very high progesterone levels in pregnancy, and this may cause the veins to become more distensible or stretchy. And the combination of this, having a high cardiac output, increase in blood volume, increase in heart rate, so this is what we call a hyperdynamic state. And the fact that the veins become more stretchy, this can result in an enlargement or rupture of pulmonary vascular malformations through pregnancy. So when do these complications occur? So really they can occur at any time during the pregnancy, but the majority of the time they occur in the second and third trimesters. And the reason for this is what I was just talking about, is it takes some time for these physiologic changes to occur, and then the body is really affected by them, and these can cause the vascular malformations to rupture. So we would recommend screening and treatment of pulmonary vascular malformations as early as possible. So after the first trimester, so after 12 weeks, and anytime between 12 and 20 weeks. And if you haven't been screened after 20 weeks, you should still get screened. For patients who've had a prior negative pulmonary VM screen, additional screening during pregnancy isn't needed in the absence of symptoms, because the possibility of developing a clinically significant vascular malformation in the years following a negative screening test appears to be quite unlikely. So what are the risks? So the risks of pulmonary vascular malformations during pregnancy and the immediate postpartum period are the same as those of outside of pregnancy. It's just that they have a higher chance of happening because of the pregnancy changes that we've discussed. So you can develop bleeding into the chest, you can start coughing up blood or hemoptysis, there can be stroke, pulmonary function can deteriorate, and there may be what's called paradoxical emboli in about 1%. So when we look at earlier studies, so again, as we've discussed, these studies are really based on case series, and there isn't tons and tons of information, but over time we've gained much more information. And earlier on in the 90s, we estimated the pre-pregnancy complication rate to be about 35%, and the mortality rate for about 9% for untreated pulmonary AVMs. And now we think that the risk of that is lower, so about 17% for non-fatal complications and about 2% for mortality. And that's really because of evolving medical therapies and things that we can actually do to treat through pregnancy. So what test should you have to screen for a pulmonary AVM in pregnancy? And so there's two ways we can do that. You can have a contrast echo or bubble echo, or a CT scan of the chest. Both are safe in pregnancy, and you know, there can be a stepwise approach. The issue really is that 50% of bubble echo tests are positive, and that means that you would need to get chest CT. So as we were discussing this as a group, we felt it was very reasonable to use a low-dose non-contrast chest CT as the initial screening test for pregnant HHT patients who've not been previously screened. And I'm sure a lot of you are sitting there thinking, well, that's a lot of radiation, and if I'm pregnant, how would that affect my baby? And I've had many talks with patients about this. And the reality is the risk is basically negligible. So, you know, we can never say there is no risk, but the risk is so low that the benefits heavily outweigh the risks. So when we look at radiation exposure for a fetus, we look at it in something, there's a value called milligrays. And so you can have up to 50 milligrays of radiation before this impacts a developing fetus. And the estimated fetal dose for a maternal chest CT is less than 0.5 milligrays. So you can see this is tremendously lower than 50 and definitely a safe test. And the same can be said for pulmonary embolization. So again, that will use more radiation, but still about 1 to 2 milligrays, so much less than the 50 milligray that would be considered harmful to a developing fetus. So this is a safe test, and it's something that would be beneficial if you haven't been screened for pulmonary vascular malformations in pregnancy. This is highly recommended to undergo this test. And then what about treatment? So you've heard about treatments of pulmonary vascular malformations and some of the sizes of feeding arteries, et cetera. So because there's not as much data in pregnancy, it's hard for us to give a risk stratification and kind of a treatment algorithm. So looking at, you know, when are we going to treat, et cetera. So we kind of have to go with the non-pregnant state because there isn't really risk stratification by size. We would assume that a larger pulmonary vascular malformation would be of higher risk, but this hasn't really been proven. And so the size threshold for treatment is really going to follow the recommendations for the general population. So pulmonary vascular malformations with a feeding artery of 2 millimeters or larger should seriously be considered for treatment, and those that are 3 millimeters or larger should definitely be treated. And if you have multiple pulmonary vascular malformations, all treatable ones should be embolized at the time of treatment. For previously treated vascular malformations, the risk of complications during pregnancy is not precisely known, but maybe around 5%. We know there is always procedure-related risk, but these risks are very small. There's a risk of bleeding, TIA, stroke, or sedation reaction, but that's less than 1%, and usually the complications are minor. So again, treatment is really recommended for pulmonary vascular malformations in pregnancy. So our expert panel recommended that pregnant people with HHT who have not been recently screened and or treated for pulmonary vascular malformations should be approached as follows. So in asymptomatic patients, the initial pulmonary AVM screen should be performed either using the bubble echo test or a low-dose non-contrast CT, but a chest CT, when performed, should be done early in the second trimester. And then patients who have symptoms suggestive of pulmonary AVMs, you should be able to have access to diagnostic imaging, such as a low-dose non-contrast chest CT. And this can be performed at any gestational age as clinically indicated. So even if you're in the first trimester and you're having symptoms, having a chest CT is the right thing to do. Pulmonary vascular malformations should be treated starting in the second trimester unless otherwise clinically indicated. And there was strong agreement, and the evidence regarding pulmonary vascular malformation is probably the best quality of the evidence that we have in people with HHT. So the next thing that we're going to discuss about reasons for pregnant people with HHT to be followed at a tertiary care center. So are pregnancies in people with HHT really considered high risk? So what does high risk mean? So high risk is a label that we use to describe situations in a pregnant person, the fetus, or both are at higher risk of complications during pregnancy, labor and delivery, or postpartum when compared to what we would define as a typical pregnancy. So most pregnant people with HHT will be labeled as high risk, really due to the nature of the disease and the risk of developing complications of pregnancy in the future, such as worsening epistaxis, anemia, or vascular malformations. So people who have been diagnosed with HHT, though that screen negative for vascular malformations, are just as likely to have what we would define as a typical pregnancy as their non-HHT counterpart. And I think this is really, an important point, because certainly we see pregnancy causes people to have increased nosebleeds and anemia. We know that in the general population, pretty much every pregnant woman will have a nosebleed, and the majority of pregnant women will end up having quite a low ferritin, and a lot will have true iron deficiency anemia. And this is going to be exacerbated if you have a pre-existing condition, which can lead you to have things like nosebleeds and anemia. So that's going to be a big thing really to address with the obstetrician or other healthcare provider who's taking care of you. And that's if you don't have any other vascular malformations. So many pregnant people with HHT will initially be seen in centers without expertise in treating HHT, and likely you would be labeled as a high risk, probably because a lot of physicians who are taking care of you may not know a lot about HHT. So they may refer you to see a doctor at a high-risk center or maternal-fetal medicine specialist, and that person can go through your history and decide whether or not there's truly high-risk component to the pregnancy, or whether it's more of a typical risk of pregnancy. And this will also lead to actually where you can deliver the baby. So pregnancy in people with HHT should really be approached by a multidisciplinary team, and this will include, initially your family doctor and obstetrician, and then may include a consultation with a maternal-fetal medicine specialist. Obviously, your respirologist will be involved, an anesthetist, and then if you need to have any types of interventions, all of those physicians would be involved as well. It would be important to have a, again, antenatal or before you deliver consult with the pediatrician, just to talk about, what you've decided on in terms of genetic testing, if you want to test the baby at birth, what are the pediatric implications, etc. So that's a good thing to do as well. So again, HHT patients with really minimal disease can be managed at a tertiary care center preferentially, but at that tertiary care center, they may be advised that they're actually generally low risk. And then a recommendation may be made for care and delivery outside of that tertiary care center, so more close to where you're living. And this would be done on a case-by-case basis. So when we stratify risk in pregnancy, so when we're going to attach this label of high risk, and then we have to think about, okay, are you actually a moderate or lower risk? So how do we make that decision? So there's a 1% overall risk of complications in pregnancy in patients with HHT, and the risk stratification is really based upon the results of the vascular malformation screen or treatment. Highest risk people are going to be unscreened pregnant people with HHT. So if we don't know specifically if you have a pulmonary vascular malformation, that would be the highest risk. Those with known but untreated or not yet diagnosed pulmonary vascular malformations would be the next highest risk. Pregnant people with treated pulmonary vascular malformations are also at risk because some very small or previously undetected pulmonary AVMs may actually increase in size in pregnancy because of the reasons that we've talked about. And then when we think about pregnant people who have brain AVMs, the highest risk patients would be pregnant people with HHT and a known brain AVM with a recent clinical bleed, so less than 2 years ago, or if they've had previous bleeding during pregnancy. And pregnant people with a complex brain AVM may require a neurosurgical opinion because of the higher bleeding risk. So our expert panel recommends that pregnant women with HHT be managed at a tertiary care center by a multidisciplinary team if they have untreated pulmonary AVMs and or brain vascular malformations that have not been recently screened or treated for pulmonary AVMs. So that's kind of a long way to say, if you haven't been tested for pulmonary AVMs, this is the time we really need to do it. And until we have those results, we have to assume that this is a much higher risk pregnancy. And once we get the results, we'll be able to quantify that risk for you. So the last thing I'm going to talk about is whether or not you are able to have an epidural once it comes time for you to deliver the baby. And the short answer to that question is yes, you can have an epidural. And so, why are we asking this question? And the reason we're asking this question is because there are such things as spinal vascular malformations, and they're known to exist, but they're rare. And the incidence of symptomatic spinal vascular malformations is only 0.5%. They're mainly detected in the pediatric population and more of a predominantly male population. And the location is in the thoracic spine, which is really in the chest. And an epidural is very low. It's down in the lumbar region. And so a lot of them don't extend here. And most of them, 28 out of 29 that we have, are what's called perimedullary. So what does that mean? So when we look at a picture, so this is basically the back, and then this is the needle. This contains the anesthetic. So we put this into this space, and the spine is covered by something called the dural sac. So the spine is inside this sac, and this goes epidural. So that means outside of the dural space. So you don't actually go into this space. There are cases in which, though, the needle can puncture this, and there are specific things called a spinal anesthetic where you actually purposely go into the dural space. So, but for an epidural that you would have through labor, the medication should come in through here, and the needle will come in through here. And in this region, the risks of having a vascular malformation is low. And we also know that these vessels are really going to be more up here on the spine. So basically, if the epidural is done correctly, there is no risk of anything happening with this because of where the vascular malformations are likely to be. So, you know, people, of course, it's hard to do a study on this where we look prospectively. So we have to look back and see what has happened to people who've had epidurals and in pregnancy. And so there's two large studies. So we looked at, there was 185 deliveries here and 484 pregnancies in this study. And there were a lot of epidurals and spinals that were done, and there has been no report of spinal hemorrhage or complications in these studies. And there's really no case reports of pregnant people with HHT developing any kind of complication of spinal vascular malformations during an epidural or spinal anesthetic or during pregnancy and delivery. There are a few case reports of patients who don't have HHT who have developed a post-epidural or spinal complication, but these complications were always treatable. So in terms of screening, so how do we actually screen for this? So if you weren't pregnant, we can do a contrast or an MRI using contrast, and that contrast is gadolinium. We don't use gadolinium in pregnancy, so we'd have to use an unenhanced MRI. And that will really only exclude medium or large spinal vascular malformations. And because of their location, this perimedullary location, it doesn't really influence the rupture risk or the theoretical risk of epidural anesthesia. So screening the general HHT population for spinal vascular malformations is not recommended, but it is prudent to have the epidural or spinal anesthetic performed by an experienced anesthetist. And that being said, it would be worthwhile to have an anesthetic consultation prior to coming to labor and delivery. Again, because this is a rare condition and the anesthetist may not have encountered patients like this, it's worthwhile to go through this with the anesthetist and come up with a plan so that when you come to labor and delivery, the anesthetist who may be on call won't say to you, oh, you can't have one because you have HHT. And this is why I think this is really one of the most important things coming out of this guideline. And you know, if nothing else, to be able to come to your doctors to say, I can have an epidural, and this is what's coming out of this large consensus group. I think this is really going to be a game changer for pregnant people with HHT. So our expert panel has recommended not withholding an epidural because of the diagnosis of HHT, and that screening for spinal vascular malformations is not required. You may have screening, but it's not required. So this brings me to the end of the presentation of what we had discussed in the guidelines. And you know, if you go to hht.org, you're able to find some of these things basically summarized in the pamphlet about pregnancy and HHT. And also this very handy checklist. And I think this really goes over things to discuss with your doctor at pre-pregnancy consultations as well as throughout your pregnancy. And so this concludes my presentation. And of course, I'm happy to take any questions.
Thank you very much, Dr. Lausman, for a very informative and engaging presentation. We do have quite a few questions. We'll try to get through as many as we possibly can.
Sure.
So the first question, regarding genetic testing for pre-implantation in utero and cord blood, which is offered to parents with a confirmed genetic diagnosis, are there options for parents with mutations of unknown significance?
Okay, so I guess I'm not sure. The reason I'm kind of pausing is because of the word significance. So I think what we know is that if there's an identifiable gene or a genetic mutation of any description for any disease, then we are able to look for that, either pre-implantation for an embryo, through an amniocentesis, or post-delivery. So the answer is yes, we can look for a gene. And then in terms of whether or not it's significant, that really brings into it a lot of different kinds of questions, because there's something that is now being identified called variables of unknown significance, or VUS. And we all have these things. We all have some type of genetic mutations, et cetera. But a lot of times we don't know what they mean. And I think, again, my fundamental counseling is really, what are you going to do with this information? Is it going to change anything that you're going to do in the pregnancy? And if it doesn't change what you would do in the pregnancy, then you may or may not choose to do this, like during the pregnancy, and you may choose to screen afterwards, or pre-implantation. But sometimes we just don't know the answer. I think this is it's really kind of a whole new world out there for genetics. I think a pre-pregnancy consultation with a geneticist in a situation like that would also be helpful.
Thank you very much. The second question, does HHT skip generations?
So, I mean, I guess in theory it could, right? So an autosomal dominant condition means there's a 50% chance that your child is going to get this gene, but you may end up not passing on the gene. And so then if none of your children have it, then they're not able to pass it on. So that could theoretically be the case. And again, that's something that we can test for, which is really great in the era of 2021.
Thank you. Is there any risk of a baby having a stroke during pregnancy if the baby has a brain AVM? Sorry.
Very good question. So again, I think it's a hard question to answer, because it's really going to be a theoretical type of situation. So let's say we know that the baby has HHT. The chance that they're going to develop a brain vascular malformation in utero is probably quite small. I can't give you a number for that. And then having a fetal stroke, is also a very rare event. So that's not to say that things like these can't happen. I think the really great thing nowadays is if you're followed in a maternal-fetal medicine center, where there's ultrasound on site and you're able to see the maternal-fetal medicine specialist after your ultrasound, then we can identify things throughout pregnancy that can change. So the brain is developing through the entire pregnancy. And sometimes we identify that there is normal brain development at the 20-week scan, which is when we routinely scan for anatomy. And then we see changes, or there's been a bleed in the brain or something like that later on. And then I brought up, we are able to do a fetal MRI as well. So if those types of changes occur, there's definitely something that we can screen for through the pregnancy and look for and deal with as if they arise. But I think it would be an exceedingly rare phenomenon, and I don't think I would put that on my top list of things to worry about.
Thank you. So this is a question regarding OHIP, or insurance. So does having HHT cover in vitro fertilization through OHIP if there's a chance the fetus may have HHT?
Okay, so that's the great question. So basically, I know this is an HHT Canada talk, and so this would be I know about the specific guidelines to Ontario, but it probably is the same across Canada. So right now, you're not excluded from IVF funding if you have a pre-existing condition. So it doesn't matter what the pre-existing condition is. You are allowed to sign up for government funding, and they will fund one IVF cycle for you. I think that, in terms of screening, so the pre-implantation genetic diagnosis part would likely need to be paid for yourself, but the other parts of the IVF would be funded by the government.
Thank you very much. I think we have time for one more question. Is it safe for an HHT patient with a history of brain AVMs and aneurysms that have been treated and currently has pulmonary AVMs to give birth?
Okay, so that again is going to fall into the case-by-case basis scenario. So I think, a person like that would definitely need to be evaluated pre-pregnancy. We need to make sure, again, that everything was optimized. So the pulmonary vascular malformations were treated. We want to look at what the pulmonary function was, things like that. We want to take a look at, and then at the brain vascular malformations. What has their treatment been? What's the neurosurgical opinion about risk, et cetera? And then really take a look at those risks and say, okay, what's the risk of pregnancy now based on these things? And I think if you've really optimized the treatment as much as possible, then it is likely possible to proceed with a pregnancy. The other option that I think is really becoming more mainstream nowadays. So let's say, you saw a MFM specialist and you had a bunch of opinions from lots of people, and people said, you know what, having this pregnancy may be too high risk and we're really concerned about your health through the pregnancy. Surrogacy is really an option that's available, again, as a more mainstream option. And this would be something where basically you would undergo an IVF cycle. So it would be, your own egg and your partner's sperm. You would create embryos, and this would be implanted into a different woman, and she would deliver the baby, and the baby is genetically yours. And I think that, that's a great option for people who are at very high risk in pregnancy. And that's, as I said, a case-by-case basis. But I think that ultimately, if you want to have a baby, we can make you have a baby. And I think that that's what the community needs to know.